version of the JVS Online Journal Club. We're thrilled today to have St. Louis University and UT Southwestern hosting the May version of the JVS Online Journal Club. We have two great articles, which we're excited about. The first is Prospective Evaluation of Upper Extremity Access. This is the recording is in my way, sorry. And total transfemoral approach during fenestrated and branched endovascular repair. And then we're going to be talking about percutaneous thrombectomy for acute limb ischemia is associated with equivalent limb and mortality outcomes compared with open thrombectomy. From UT Southwestern, Dr. Carlos Timuron will introduce the first article and give us some background. And then the first year vascular fellow, Dr. Michael Sang from UT Southwestern, is going to present the paper. For the acute limb ischemia paper from St. Louis University, Dr. Matthew Smeds will introduce the topic. And then the third year integrated resident, Dr. Mark Award, will review that paper as well. We're excited to have authors from the acute limb ischemia paper. Dr. Marissa Jawasinski is a fourth-year research resident at UPMC, and the senior author is Dr. Catherine Reitz. She's actually the second-year fellow, and then we'll have Dr. Saradian is also joining to review that as well. Our editorial board members and discussant for tonight is Dr. Elisa Greco. She's done this before. She's been a participant, and we've loved having her before. She's from the University of Toronto, program director. She's also the wellness lead for the Department of Surgery at St. Michael's Hospital and the director of the vascular lab there. And then also very exciting to have is Dr. Javaria Fatima, who is an associate professor of surgery. She's at Georgetown. She's the co-director of the Complex Aortic Center at MedStar Heart and Vascular Institute. And we're thrilled to have her discuss and help us understand a little bit about the transfemoral paper for endovascular repair. We ask that you please stay muted. We're going to have you put your questions and comment in the chat. The moderator may call on you to speak if the question is a little complicated. We do record this for on-demand access. We will not be having the June version of the JVS Online Journal Club. We'll be seeing everybody at VAM in June, but we will be back in July. We'll have the Young Surgeons Committee again host the JVS Online Journal Club for July, and that's going to be Wednesday, July 10th at 6 p.m. Central Time. All of the dates for 2024 are posted at vascular.org. And it's also sent out in the links are sent out in SVS Connect, both on the general forum and also for the program directors. So I will stop sharing my screen. And at this point, we'll turn it over to Dr. Timuron.
Thank you. It's a real pleasure to be here. Let me share. Perfect. You can see my slides, I hope.
We can.
Perfect. So these are my disclosures. We'll be talking in this introduction about some investigational device, and I always want to acknowledge my dear friend Gustavo Aldrich. He always shares not only the beautiful illustrations that his artist does for him, but also his experience. And, you know, he's obviously the senior author of the paper that we're going to present and discuss. I want to start by mentioning that the issue about which access to choose for these complex endovascular repairs is something that we've been actually studying for quite a while. In fact, you know, we looked at this a couple of years ago using the Aortic Research Consortium database. And the reason is we were very comfortable doing upper extremity access. That's the way we did these procedures when we started doing them within our IDEs. But when the steerable sheets became something that we were able to access easily, we actually were able to use them to switch from upper extremity to transfemoral access. So within the consortium, we had the opportunity to review all these cases that are done within investigational device exemptions protocols, but also these are devices and data that we collect and are externally audited and is reported to the FDA regularly. For this particular study in which we review our outcomes based on access, we use all cases performed within a 15-year period, and those were almost 1,700. And interestingly, 2/3 of those were used with upper extremity access, and that's primarily the first 10 to 12 years. And only later where we switched to lower extremity access. And what we found is that there was, although the 30-day mortality was almost the same for both upper extremity and lower extremity access, is the stroke and TIA events that were slightly more frequent when we use upper extremity access, 2.8% versus 1.2%. Now, these numbers are relatively small. However, it was clearly statistically significant more cerebrovascular events when we use upper extremity access. When we assess a stroke and TIA separately, obviously the numbers were really small, and we didn't see those that the differences were statistically significant anymore, but the trends were clear. And so obviously that led us to conclude that we felt that, let me stop sharing, that there was a concern for more frequent events, cerebrovascular events with upper extremity access. And that pushed us to actually start, I think within the consortium, most of us have switched to use preferentially transfemoral access for most of these procedures. Now, whether that translates in better outcomes, we don't know yet. I think it's something that will be examined in the near future, but I think it's something that each of us individually have tried to assess. And I think that's how Dr. Aldrich and his group in Houston had put together their experience. So that would be the introduction. I guess Dr. Zahn now will present the paper and go over the results.
I want to thank everyone for the opportunity to share this paper from Dr. Odrich and the team from UT Houston and the Mayo Clinic. So a little bit of background, like Dr. Timran was talking about, but also, the fenestrated and branch endovascular aortic repair has actually surpassed open surgical repair as the most common intervention for these complex abdominal aortic aneurysms and the thoracoabdominal aortic aneurysms. Currently, depending on which paper you look at, anywhere from 30 to 80% of patients treated with a fenestrated branch EVAR use an upper extremity approach. The development of steerable sheaths and also the more flexible and lower profile bridging stents such as the VBX right here and the iCast have enabled increased use of this total transfemoral approach. And this is just a picture alluding to Dr. Timran and Dr. Shamzazmi's paper from last year, looking at the ARC data of the upper extremity compared to the lower extremity axis. So the purpose of this study was to compare the outcomes of the two different approaches. All these patients were prospectively enrolled between 2013 and 2022 and were treated by a single principal investigator at 2 separate centers. The patient anatomy was evaluated using Terra Recon and then treated using either an off-the-shelf multi-branch such as this one or a patient-specific fenestrated branch stent graft. The type of approach varied during the study period. Before 2017, a left upper extremity access was routinely used, and this is a picture depicting that. After 2018, preferential right upper extremity access was used, and then following 2021, a total transfemoral access was preferred when able, and upper extremity access was limited to difficult anatomy, which included excessive angulation and tortuosity in the renal or mesenteric segment. They described upper extremity access as performed using a brachial cut down and a 12 French 45 centimeter flexible sheath to engage the target arteries using a staggered catheterization technique. And this is an example of one such sheath. This is a dry seal, and this is a picture demonstrating their technique. Each target artery was then stented over a 0.35-inch wire through a 7 or 8 French coaxial sheath. The transfemoral approach was done using a pre-closed technique for the bilateral groins. And then the branch vessel cannulation was obtained using a 12 French sheath with a 8 French 55 centimeter aptus steerable sheath and a stabilizing buddy wire. And then instead of a dilator, a 6 French 90 centimeter shuttle sheath. This is a picture demonstrating the through wire as well as the shuttle sheath in place of a dilator in order to cannulate the branches. The primary endpoints were technical success, 30-day cerebral vascular events, and any major adverse events. The success was defined as a successful deployment of the stent graft with patency of all target arteries and no type 1 or type 3 endoleak on completion angiography or cone beam CT. Cerebrovascular events were defined as any stroke, TIA, and or neuroimaging findings consistent with stroke. And then any major adverse events included all-cause mortality, MI, prolonged intubation, renal function more than 50% decrease from baseline, acute renal failure, bowel ischemia, major stroke, and or paraplegia. Secondary endpoints were target artery-related adverse events and procedural metrics. A total of 551 patients were enrolled. 366 were upper extremity and 175 were total transfemoral. As you can see, they collected a number of pretty normal demographic and comorbidities, and as well as the aneurysm extent. Of note, the only things that were significant were cigarette smoking, an ASA score greater than 3, which was lenient towards the transfemoral arm, and then a maximum aortic diameter, which was significant, leaning towards the upper extremity arm. A total of 2,100 renal mesenteric arteries with a mean number of 3.9 target arteries were stented per patient. There was no significant difference in the proportion of patients treated with 4 or more target arteries in the upper extremity versus transfemoral approach. And total transfemoral approach was used less frequently for grafts with directional branches, and this was significant. Cases with a total transfemoral approach had fewer cases with concomitant TVAR and a prophylactic CSF drain. Patients with a total transfemoral approach had a shorter total procedural time, 193 minutes versus 250 minutes. They had a shorter endovascular time of 150 minutes compared to 170 minutes, and a decreased fluoroscopic time of 71 minutes compared to 83 minutes. Transfemoral approach had a lower EBL, which was also significant, and there was no significant difference in the cumulative radiation between the two groups. It was 1.6 versus 2 gray. Intraprocedural target artery adverse events occurred in 21 patients with upper extremity access and 26 patients with transfemoral approach. The most frequent adverse event was a dissection in 21 cases, and the second most frequent target artery adverse event was perforation in 13 patients. These adverse events relating to the target artery led to 11 technical failures. There was no significant difference in 30-day mortality between the upper extremity and the total transfemoral approach. And the incidence of major adverse events was lower in patients treated with a total transfemoral approach. 10 strokes, 3 major and 7 minor, were all for upper extremity access patients. And these were equally distributed between anterior and posterior cerebral vascular circulations. There was no significant difference in the major adverse events between the separate study subgroup periods when they looked at the early period, the period where they did the right upper extremity access, and then the total transfemoral access. 237 patients were treated with devices that had at least one directional branch. and the aneurysm extent of the branch cases were 16% of the complex abdominal aortic aneurysms and 84% thoracoabdominal aortic aneurysms. However, this wasn't statistically significant between cases treated using the total transfemoral or the upper extremity access. The average number of branches for each of these cases was 2.6 for both arms, with the majority having at least 2 branches. There was a shorter operative time for the total transfemoral approach, even among the branch cases, but the other variables were not significant. Upper extremity access was previously thought to be necessary for these directional branch grafts. The shift to a total transfemoral approach reflects advancements in these ancillary technologies. There were strategies that were utilized to minimize pelvic ischemia, including downsized to 12 French sheaths after deploying the device and delivering the device to the side with an occluded hypogastric artery if there was one. Spinal cord ischemia was observed as similar between the 2 branches, especially when adjusted for aneurysm extent and branch device utilization. These advancements have enabled an increase of transfemoral cases from 8% in the early stages to 96% from 2021 to 2022. And the technical success rate has remained the same despite changes in technique while concurrently decreasing the operative time and major adverse events. The difference in stroke between the 2 arms likely reflects the study design and the extent of repair between the upper extremity and the total transfemoral cases. Of note, silent lesions were not assessed with MRI, where another study identified an 80% infarction rate, despite having only 13% incidence of symptomatic strokes. There were several confounders for similar radiation exposure among the 2 arms, and these included different patient positioning throughout the study period. Initially, they started with arms tucked and then progressed to using arms overhead. The type of imaging unit used for the cases varied, and then the relocation of the principal operator. And then lastly, the study is limited by inherent bias due to the increase in clinical experience over the study period. Lastly, there's an uncertain generalizability, as this is a single operator study, and we don't know if this technique in the community or broadly will have the similar results. So in conclusion, I think this paper, it really shows that a total transfemoral approach is very feasible and in the right patient, potentially even safer than upper extremity access, with decreased chance of stroke, decreased operative time, and decreased major adverse events. Thank you.
Great job presenting that paper and the data. So, I think this paper really kind of sort of mirrors the practice of most of the people who are involved with this complex aortic practice. So, way back when everybody used to kind of go through the arm access, when I started doing these, I also was primarily using upper extremity access, first with a cut down, and then went on to doing some of these with just perclose or percutaneous axillary access or high brachial access. So, but over time, you've kind of sort of all evolved along with the technology that has evolved as well. And along with some of the sheets, these steerable sheets they really work like magic. So they work very well to allow you to get into the branches, get into the fenestrations, and essentially even reduce the number of catheters that you're using to do these. So as you can see presented already, from their initial use of upper extremity access, first with the left arm, then they went on to the right upper extremity access in the thought process that, less manipulation and less navigation of the curvature of the aorta would reduce strokes, and then eventually kind of going completely transfemoral. So one of the questions that I would pose here is, in my practice, I would say that I've gone completely transfemoral. The only patients who will get an upper extremity approach would be someone where I don't have a contralateral access. If it's occluded, I would recanalize and use it. But if it is somebody who already has an AUI and they have a failed EVAR, in my practice, that would be someone where I would use a transfemoral brachial access or upper extremity access. So I think Gustavo's not here, but Carlos, your practice is very, very similar to his as well. When would you use upper extremity access compared to transfemoral? What's your algorithm for it?
I agree. I think most of these cases can be done from below. I would say in my current practice, maybe 95% going from using just transfemoral access. I do believe that most situations can be done from below, even when you have tortuosity or angulations. We used to think that dissections because of the small true lumens were another issue, but now, we can actually enlarge the true lumen or get a single lumen. And so those cases also can be done from below. I have to say that, it took me a while because I thought upper extremity access was the way to do it, because it was very smooth and quick and fast. And it has some advantages. The fact that you release the device sequentially, the fact that you secure all your vessels, that you can actually place the bifurcated device from below or the legs from below before you extend the vessels, especially when you're using fenestrations. It's a clear advantage. The one thing I miss, for instance, is the ability to pull the device from above rather than pushing the device, which is actually something nice to do when you have a lot of tortuosity angulation of the iliacs or even the aorta. This true access where you actually pull the device from above more than you push from below is something that works really well, especially what I said, when this angulation, so when there is a previous device, when you have failures, because when you have a device there, the elasticity is lost. Now you're asking me when I use it. I'm basically with you when there is contralateral iliac occlusion that for whatever reason you cannot recanalize or it's not a good idea to recanalize. I try to reopen those when I can. But I still, maybe I may do it when there is the angulation or tortuosity is really bad. And I think I
help get the device up.
need more control to, yes, access the target vessels and do some sequential. Or I think it's going to be very hard to, advance the device from below because of the tortuosity. And I have to say, yes, the longer quiz or the stiff wires can help, but even in those situations, sometimes it's very hard. Although I have to say, in some situations, I just do radial access and do transfemoral access, transradial all the way through and through. And
yeah, if it's just to get through access and push the device up and use that to kind of tug the device in, yeah, that definitely helps. So we'll move on to the next question. Paul Demouzier, you asked a question. I think that's a great point. It seems like steerable sheets are the key here in reducing time or flora. How much might this be attributable to learning curves or advances in imaging? Does anybody want to take this, or I can certainly help answer that one? Do you have any takers for that one?
I think you and Carlos can start that conversation.
I really think steerable sheets have been the game changer. Without them, we couldn't have done that. And, I think Carlos made a point about dissections where you have a narrow true lumen. So, you have steerable sheets that have a 9 millimeter curve versus 17 millimeter curve versus some have even larger. So I think the 9 millimeter curves worked very well for those. If you're trying to get into branches, some of the longer curves also help with really doing that. And as far as radiation, interestingly, in this paper, they didn't really find any reduction in the air karma between the upper extremity and transfemoral, which is very surprising to me, because it's not just the fact that, there's a time bias from the early use of upper extremity access to the latter part of the study where they're using more and more transfemoral, but it's also the fact that, the technology is better. In Siemens, we had the XXLD, which reduces the radiation. In some of the newer Philips Azurion, we have a significantly lower radiation, digital zoom, extreme collimation, and we all kind of put the arms up for these patients now way more than we ever used to do before. So I would have expected that in the latter half, there should be a significant reduction in radiation, which, I'm not sure why they didn't really see that, but perhaps it may be that they went from a much more advanced unit to potentially maybe a little bit of an older machine, because that can definitely offset some of the benefit that they may have seen. But yeah, I think steerable sheet really does help reduce that. We'll go to the next question. Go ahead.
But I do think that that's an important point. I think we learned to do fenestrated and G using upper extremity access. And when we switched to transfemoral access, we knew how to do it. So even though, yes, the steerable sheets may be the game changer, I think we also knew how to deal with
Yeah.
the target vessels, with the deployment, with all that. On top of that, the newer stents, the bridging stents, lower profile, all that makes
Lower
it.
profile, yeah. And they should all reduce radiation, all of those things. Yes. So the strokes are more related to right upper extremity axis versus left upper extremity axis. Is there any selection bias with the femoral axis? I'm not sure they specify that in the paper. In your experience, did you think there was a difference?
No, I want to say that we, in our study, when we examined the consortium, the first 1,700 patients, we didn't see that. In fact, right upper extremity axis had a 2.5% stroke and TIA rate versus 3% with left. So interestingly, the right had a little lower. Obviously, that was not statistically significant, but we didn't see any difference between the two sides, right or left.
Yeah.
You may think that because you're crossing the entire arch from the right side, you may have more. In our institution, for instance, all the strokes we had, we saw them with right upper extremity axis. But again, when we analyzed the consortium data set, we didn't see that. It was equal, or actually slightly lower with right upper extremity, which I don't know why that was. But anyhow, I don't think there is a significant difference. I think once you are doing from above, probably you will have a small but a higher frequency of cerebrovascular events.
Varia
in
and
this
Carlos,
paper.
haven't there been other studies that have looked at upper extremity access? Not just the one you mentioned, Carlos, but in just other areas, and shown that right upper extremity access doesn't have an increased risk of stroke?
Yes, that's a good point. Several people have looked at that, and I think most people haven't found significant differences. Interestingly, the cardiology literature for PCIs does not show a significant difference between right and left either, which is also, another point of data that supports the fact that, you can probably use either one.
Or avoid it altogether if you can.
Or avoid it altogether.
Yeah.
But I do have to say that the numbers are small, and if you feel that you need it, you should use it. I don't think you should be dogmatic about just doing it from below. I think obviously it's preferable, but if you need it, I think you could use it.
Yeah. So I think Misty, you have an excellent question. What implications does this work offer those who are going to start using TAMBI in the near future?
That's very important.
That's a great question, because I think the way, if you go by IFU, and it requires that trilumen catheter from the arm access, and then get your through and through wires, and then advance the device. So it's a preloaded system. So I think you're kind of obligated to use upper extremity access for the TAMBI. So it's a little bit, for those of us who've gotten very used to doing it all transfemoral, it's going to be going back in time and kind of doing it a little bit differently. But it does have the preloaded catheter, so that certainly makes things a lot easier and quicker, actually, as well. Will reduce the time because it's all preloaded. Because right now, none of my devices, I preload any of those. So I think there's a give and take in there. But definitely, it's a little bit of going backwards, at least in my book. What do you think? What's your experience? What's your thought process?
Now, Misty, I think we did like 7 or 8 cases in the TAMBI trial. And obviously we had to do it using, using IFU. So we did it from above. Having said that, I look carefully at trying to do it from below. I think it's doable. I don't think it's as easy as with the devices we use now, because they're different, the branches are separate. And so it's easier, you have a little more room. In TAMBI, it's harder to see also. But I'm dying to do the first 2, which I think I'm gonna have to do under IFU, because there's gonna be, post-marketing. I'm dying to do it from below.
Well, I'm glad that you're already planning how to use this new device off IFU. That is exactly not what I think we're supposed to promote at this journal club. But
yes,
no, I
Misty.
I'm just saying that
you should not say that.
I'm just saying that most people will probably try to do it, just because, again, there is compelling evidence that trying to do it from below is preferable.
Well, thank you
Thank you,
both for a
Hal.
lot of great conversation, because this is something that's going to become more and more common in our practice. We're going to shift gears now, and we're going to have Dr. Smeds open up the topic of acute limb ischemia.
All right, can everybody see my screen and stuff? So thank you for having our group present this interesting research paper from the Journal of Vascular Surgery portfolio of journals. I have no disclosures relevant to this talk. I'm sure I don't need to review for this audience, but acute limb ischemia occurs with a sudden cessation of arterial flow to a limb due to either embolism or thrombosis of a blood vessel, and may present in an acute fashion or more insidiously with a subacute presentation. There's no defined treatment, but many treatment options exist, including medical and anticoagulation, as well as surgical and endovascular techniques with the goal of revascularization. These procedures are not without difficulty. The patient population is often sick and often late in arrival and diagnosis and carry significant comorbidities. Minor limb loss or major amputation are very real outcomes, and these procedures may carry high morbidity and associated mortality rates. Patients will present with the pathognomonic 6 Ps of ALI, which include pain, pallor, pulse deficit, poikilothermia, paresthesias, and paralysis. And depending on these clinical findings, patients can be organized into the categories based off findings at presentations outlined in the Rutherford's classification. These range from category 1, a disease that denotes a viable leg that is not immediately threatened, and increase to grade 3 that exists in profoundly ischemic limbs with paralysis that usually predict major limb loss or permanent nerve damage that will result in significant morbidity. Patients within grade 2 can often be salvaged if treated in an expeditious manner. After anticoagulation, there have been several interventional strategies classically described for ALI, including open surgical options such as thrombectomy, and bypassing catheter-directed lysis, during which a catheter delivers lytic agents directly to the culprit thrombus over 12 to 72 hours or longer. There are, however, significant differences in time between these procedures, with most patients in higher Rutherford's categories undergoing surgical revascularization, which is quicker than directed lysis. Over the years, there have been several studies that have compared catheter-directed thrombolysis to surgical management of ALI. Most notably the STYLE trial, TOPAZ trials, Rochester study, that demonstrated efficacy of both treatment strategies with surgical options best suited for chronic disease, and both showing similar outcomes for acute disease of 2 weeks or less duration. Recently, there's been an explosion of endovascular devices that help clear arterial occlusions with the aid of mechanical or pharmacomechanical thrombectomy, which does offer a potential strategy of treatment of patients even with higher Rutherford categories in an expeditious manner, which leads us to our paper that we're looking at today, and that is percutaneous thrombectomy for acute limb ischemia is associated with equivalent limb and mortality outcomes compared with open thrombectomy, authored by Marissa Jarozinski and co-authors from the University of Pittsburgh. With that, I'll turn over things to our third-year integrated vascular surgery resident, Mark Awad, who will present the paper in more detail.
All right. Hopefully you guys can all see this. Thank you very much for having us on. We'll be discussing the paper entitled Percutaneous Thrombectomy for Acute Limb Ischemia. It's associated with equivalent limb and mortality outcomes compared with open thrombectomy. The author's hypothesis essentially was that their primary outcome was a composite in-hospital major amputation or death among patients receiving percutaneous thrombectomy and open thrombectomy with a diagnosis of acute limb ischemia. Secondary outcomes included ipsilateral major amputation, death, in-hospital reintervention. This included stents, lysis, additional PT, OT, or bypass. An extended length of stay. This was defined as greater than 75th percentile for entire thrombectomy cohort. Study's design was a retrospective analysis of national inpatient data for 5 years from 2015 to 2020. They included patients who were greater than 50 years old, had a diagnosis code of acute limb ischemia, and underwent revasc within 2 days of admission. They excluded patients who were less than 50 years old, had a diagnosis of trauma or dissection, and patients who underwent lysis at their index thrombectomy, whether it was percutaneous or open, and procedures after 2 hospital days. Their final cohort had about 24,000 patients, 30% of which were done percutaneously and 2/3 done open. The results, major amputation or death happened in about 10.6% of acute limb ischemia patients, all comers. There was no difference noted between the percutaneous or open options. And for major amputation, happened about 4.7% of acute limb ischemia hospitalizations. Again, no difference between groups. Death, 6.3% of patients with acute limb ischemia diagnosis, and no difference between the groups. For in-hospital reintervention, it was 10.4% of patients in total, and there was significantly more in the percutaneous group versus the open thrombectomy group at 15.7% and 18.1%, respectively. Extended length of stay occurred in 25.9% of acute limb ischemia patients, and it was significantly less in the PT group versus the OT group, 22.6% versus 27.4%. So what does affect the author's composite endpoint? Amputation and death. Everything marked in red here was noted to be significantly affecting the composite endpoint. So that included peripheral artery disease, multi-level, and fasciotomies needed. Which factors affected in-hospital amputation? Peripheral artery disease again, smokers, and depending on how distal the level of thrombectomy needed was, femoral popliteal or tibial. Which factors affected in-hospital death? Again, everything marked in red here. So that was PAD, AFib, multi-level, fasciotomy, and interestingly, in-hospital death was reduced depending on how distal the segment was. Which factors affected in-hospital reintervention? Most notably here was percutaneous thrombectomy right at the top of our chart here. Additionally, region and whether the hospital was large, PAD, and again, multi-level thrombectomies. Which factors affected length of stay? Notably, you have insurance this time, whether it was Medicaid, self-pay, also PAD, AFib, hypercoagulable disorders, and fasciotomies. Limitations were noted. The study used ICD-10 codes, which did not capture many of the characteristics we often look for, like Rutherford classification, the reason for reintervention or fasciotomy, laterality, and device data. Long-term percutaneous thrombectomy outcomes are still pending, and that's all we have. Thank you.
Sorry, Mark.
Sorry, go ahead.
Sorry, Mark. It's Kevin Tallman up in Indiana. So remind me in this, and again, it's over, a fairly wide swath of time. And of course, devices and techniques actually evolved quite a bit in that 5+ year period. Did they make any mention, and maybe there was no way retrospectively to extract this data, did there seem to be any increasing trends favoring the percutaneous thrombectomy procedures, different in 2015 or 16 versus towards the end of their study period?
Well, Kevin, one of the nice things about this is that we have the authors here. So the authors can actually answer your questions if you want to address it to them.
Sure. Same question.
I can take that question. So we actually didn't see a significant difference in device utilization over our time period. It's not actually published in the paper, but we did look at it. there wasn't a significant trend.
Thanks.
All right, thank you. Sorry for my voice, but I'm going to try to do this best as I can here. This was a great review. Some things I noticed, I mean, I know it's a limitation of the database, you don't have Rutherford's classifications, but if you use time to surgery or time from initial onset of symptoms and the need for fasciotomies as a surrogate for Rutherford's classifications, it seems like most of the patients were in 1 or 2A because they mostly didn't have fasciotomies, or you even use 2 days. To me, if I'm operating on acute limb ischemia 2 days later, well, you know, again, it's something that could wait. So I'm not sure that, so I want to know, how do you think that affected things? And maybe it's, again, a resource issue, but here, you know, it's not really controversial as to whether or not to treat a Rutherford's 1 or 2A with percutaneous thrombectomy. We really use thrombolysis as a rescue if neither of those other 2 options exist. So did you use those as surrogates, and how do you think that affected the data?
So we use fasciotomy as a surrogate. I'll kind of start there. Looking in the literature, I've seen kind of different strategies for fasciotomy use. I've seen kind of the prophylactic fasciotomy being used fairly broadly, kind of like, if you think of it, you should do it. And then there's also centers that report using fasciotomy almost exclusively therapeutically at about 5%, which in our data set, I think it was about 6%. So it's likely underestimated. I'm assuming that many coders are not adding on an extra fasciotomy code. In terms of the days, we picked 2, but did an additional sensitivity analysis where we limited it to procedures that were done within 1 hospital day, and still did not see a difference in our results.
Great. There's a question here in the chat. And again, similarly here, is it just surgeon preference, or is it resource availability? You know, the bigger hospitals maybe have more of these fun, fancy tools, and some of the smaller ones don't. Or, you know, here we collaborate very much with our interventional radiologists, so we do the procedures together. Whereas maybe these are mostly done with vascular or else. So is it surgeon preference or user preference maybe?
I think a lot of factors can go into it, which unfortunately we can't necessarily capture here. But if the only person available is IR, of course, they're going to use any percutaneous technique possible. If you have more hybrid room availability, that'll kind of lean towards more endovascular cases, individual surgeon comfort, whereas somewhere else where maybe you don't have that hybrid room availability, you're going to lean more towards open, or that's, you know, the way you trained and you're still kind of going that way. There's a lot of different kind of surgeon preference, regional preference, practice preference, but also selection bias of the patient. If somebody has had 3 groin cut downs, maybe you don't want to do a 4th. So there's a lot that goes into that decision making.
Yeah, definitely a limitation of the databases, but you know, it's what we have. And like you said, the coding is also key to getting a lot of this information. With respect to some of your findings here, you found like PAD was increased the risk of amputation, but at the same token, it was younger patients that had higher amputation rates as well. So, and you use the example or the idea that PAD was maybe even protective because, and the younger patients that without PAD, you know, were more acute and they didn't have those sort of chronic other pathways. But yet again, PAD was also a risk factor for amputation. So can you explain how maybe the different findings?
Yeah, I think there's many different types of patients that present with ALI, and that kind of younger patient who comes in densely ischemic, the motor deficit that's been going on for a long time, potentially will do worse than somebody who's developed a lot of collaterals. The same side of, or the opposite side of the coin, somebody who has pre-existing PAD and has had 3 bypasses in a leg and finally thrombosis again and has run out of options, also potentially could have very poor outcomes. So I think kind of both things can exist simultaneously.
Yeah, I think the patient who's had the bypass and the native acute limb ischemia are very different patient populations, and it's very difficult to put them in the same group. You know, obviously the bypass patient has had multiple surgeries, or is already pre-existing. If something were to go down, they're higher risk of failure. So I think it is difficult to compare those two groups for sure. Was there data to suggest delayed presentation for the younger patient? I'm not sure the database would be able to capture that.
No, this database can't capture that. Our group did publish a paper a few years ago that actually did kind of corroborate the finding of higher amputation rates in younger patients, probably attributed to hypercoagulability. I can't remember off the top of my head about the time to presentation for that patient population, but that's a very good point.
All right. Oh, good question. How much should cost affect anything? We'll see when interventional radiology is paying for it. It doesn't matter. You can let them pay for it. What about cost? These toys are expensive.
I think it's an important consideration. If something's going to give you equivalent outcomes and is going to cost twice as much, I think that should give us some pause, and we should think about who we are using these techniques in. Is it the first line for everyone? I don't necessarily think so, but I think there is a place for the properly selected patient.
So along those lines, then, I know this is these your results, and that obviously wasn't a RCT, but if you would make recommendations of who you would put in the percutaneous group versus who you would choose to open based on what you found, what kind of algorithm or criteria would you use?
I think a lot of that still to be determined, and I am still working on trying to figure that out with more data. But as of now, I think any patient that you're nervous to put under general anesthesia, somebody who you surmise would have worse outcomes with open, like somebody who's a multiple redo, would be the ideal candidate for percutaneous.
Question here, are there differences in infection rates between the two groups?
That's a good question. We actually didn't look at that outcome, but that would have been a good one to examine.
You do have the return to OR information, right?
That's true. It's only revascularization, though. We didn't look at washouts or anything like that.
I think one thing Marissa is humbly leaving out is that it's really hard to study ALI. There aren't other databases that really include these data or allow her to ask these questions. And she got really creative with ICD codes to allow her to ask these questions that really stem from a patient that she saw when she was on call. So we're excited to show not only this data, but show our institutional data, which is coming, to hopefully be a little bit more colorful and add some of these more like in-depth questions. And maybe we need to look at the infection.
Okay, great. So is there plans for an RCT to look at these things, or in our future, or has it changed your practice at all yet?
I don't think it necessarily changed my practice yet. I think an RCT is warranted. It's been how many years since the 90s? 30 years since we've had an ALI RCT. I think it would be ideal. And that's certainly something that I kind of am working towards and trying to gather a lot of data to kind of build an argument for it.
UPMC is a big group. I think we can probably safely say that Marissa's data didn't stop anyone from continuing the percutaneous adventure. So we'll see.
Well, thank you for some great discussion. Two very different topics, but both bringing in the whole vast scope of vascular surgery and what we do. We want to thank everybody for joining us at the May JVS Online Journal Club. We will not be meeting in June because we'll be seeing everybody at VAM, but we will be back in July for the July version of the JVS Online Journal Club, and that will be sponsored by the Young Surgeon Society. So thank you, everybody, to our presenters, to our moderators. We're very grateful to have you, and we look forward to seeing you in July.
Thanks, Misty.
Good night.
Great job, guys. Thanks.
Thank you all. Bye-bye.